So good morning, one and all. In the meantime, let me convey my thanks to Dr. Nilesh Mohan sir and AIOC for giving me this opportunity. I am going to talk about the evolution of refractive surgery and how we have reached to the current status, whatever we are doing these days. Yeah, that's the one. Thank you. It's not. I cannot see it here.
Can you see that?
No, not. अभी शायद आएगा.
Ma'am, is that?
चलेगा. Now this is visible, perfectly visible. Yeah. So let's start. We all know that these surgical procedures are meant to correct the refractive error of human eye. But if we go to the story, this entire saga of development of refractive procedure, then it is more than 100 years old. It started way back in 1896 when Lance used some heat-based devices, something like a cautery, to correct the refractive error. And it's very fascinating that each of these procedures, they have got their own story of development. Each of these, they started somewhere in a laboratory, in an experimental setup on animal eye. And depending on the success of that, we shifted to the non-sighted individuals or blinded individuals. And if we were successful there, then we shifted to sighted individuals or the normal human eye. And depending on the success result of that, then the procedure came into market. Once the procedure has established itself, it gets the FDA approval. And it takes nearly 7 to 9 years to get the approval. And in spite of that, if the procedure is not delivering what it claims to deliver, then the FDA approval can get retracted. Something like that happened with thermal laser keratoplasty. So basically, we divide these procedures into two types, corneal and lenticular. We are not going to talk about the lenticular procedures anymore right now. Corneal we divide in incisional and laser-based. So it all started in 1939 by a Japanese scientist, Sato, who started radial keratotomy. The idea was very simple, to put multiple linear incisor in the paracentral or the peripheral area, thus the central area get flattened. But what Sato was doing, he was putting the incisor both on the anterior as well as the posterior aspect of cornea, that is both anterior and posterior keratotomy. So when this procedure was adopted by USSR and then in US, it's like 20-year gap was there. So by that time, the follow-up patients of Sato or the patients who were operated in that era, they were there in the market. So it was there for everyone to see that nearly 75% of these patients, they had developed bullous keratopathy. And that is the reason when US started RK surgery, by that time they had stopped doing posterior keratotomy. For the simple reason, now they know the advantage of or the role of corneal endothelium in maintaining the clarity of cornea. So when in US they started, they did two large studies. One is PERC, that is prospective evaluation of radial keratotomy, and another is ARC, that is analysis of radial keratotomy. And based on the 10-year data, they concluded that nearly 70% of these patients, they get the optimal visual correction. But hyperopic shift was a problem. And that was because when they were putting an incision, the inflammation which creates during the healing process, that affects the surrounding tissue also. So they wanted something which can do the job precisely without affecting the surrounding corneal tissue. So the answer was laser. It got invented in 1983 by an Indian scientist, R. Srinivasan, who was working at IBM during that time. And he had 21 US patents in his name. So he was using this laser, this excited dimer laser, for photo etching the computer chips. When his paper was read by Trokel, he got this idea that probably we can use something like this for corneal tissue also, because every photon of this excited dimer laser has got sufficient energy to break the bond between carbon-carbon and carbon-nitrogen bond, which is there in the corneal collagen. That is how the concept of photoablation came into picture, and it was given by Trokel and Srinivasan together first time. And that is how it happened. So if we talk about the major advancement, it has happened at two places mainly. One, advancement in laser technique. Another, how we are going to approach the area where we are going to do the modification, how we are going to reach there. That is where the advancement is. So if we talk about approach, obviously the first would be surface, because that is easily accessible. So we have multiple type. like PRK, LASIK, EpiLASIK, and trans-PRK. Not necessarily they have been invented in the same chronological order. But the idea here is to remove the epithelium and apply laser. This removal of epithelium can be achieved in multiple manners, be it mechanical, chemical, by using alcohol, or photoablative epithelialization, that is, by using the same excimer laser. So in PRK, as I said, the idea is simple here. We can see it here. Remove the epithelium and put the laser. But when you are removing it mechanically, you are creating nick in the Bowman's membrane. And then when you remove it, you're not going to get a smooth surface interface here. So what we decided to do, we started using this alcohol well. That will loosen the epithelium, and now we can remove the epithelium. But if we do not remove the epithelium, simply make it one side like a flap, this became LASIK. But if we do the same without using this alcohol well, by using a microkeratome, which gives a very thinner cut, that is epikeratome, this became LASIK. And finally, the transepithelial PRK, where we are using the excimer laser first to remove the epithelium, and then we will be doing the ablation in the stroma. And we'll create epithelium, this ablation profile in such a manner that there is a smooth transition from epithelium to stroma. But the problem here is, when we are cutting the, or when we are putting the laser over Bowman's membrane, we are destroying it. Plus, there is a huge neural network in the anterior part of cornea, which is also getting destroyed. So the idea here, probably it adversely affects the healing process, and that is the reason why LASIK came into picture. What they decided to do, they wanted to make a cut, shift the entire thing, the Bowman's, the neural network, to one side and then apply laser. So that was given in 1990s by Palikaris and Burato, and they called it flap and zap technique. Probably those PRK, they will try to negate my point that nothing like this happens, but that is how it all started. LASIK came into picture. So as I said, there is a development in laser also. As we started from first generation, that is preclinical, to now we are at the 6th generation of laser. What started as a broad beam, now we have a very small beam. So we can precisely ablate a particular tissue. But what is needed here, we have to reach that tissue. So there has to be a tracker mechanism. So as the laser got advanced, the tracking mechanism also got advanced. So in 6th generation, finally, we have a mechanism to negate the cyclotorsion effect also. So that is how the laser also, the excimer laser also advanced. So if we talk about now customization, mainly we have 3 types. One is wavefront optimized, one is wavefront guided, and another is topo guided. In wavefront optimized, what we are doing, we are taking the aberration data of population average. We are taking the patient's cornea, do the ablation, and try to reach it to the population average. We are not considering the individual factor here. We are considering the population average and try to make it there. In wavefront guided, what we are doing, we are considering the higher order aberration of the given patient, and then we are trying to smoothen it to make it ideal. In topo guided, what is happening here, we take the topographic data of the patient, the elevation point, depression point, and then we compare it with the ideal topographic picture, and whatever up and down is coming, we will be ablating it. That is how the customization was happening. But whatever we are doing, if we are using the microkeratome, the problems were still there because of so many flap-related complications were there, decentered, thinning, free, etc. So now we became more greedy. Now we wanted to have someone who can do the job for us precisely. And that came in the form of femtosecond laser in the year 2001. This is basically a near-infrared radiation which causes photodisruption. It strikes the tissue, it creates plasma. Plasma is nothing but electron and ionized molecule. So that spreads, that creates a cavity. So there is a clear-cut distinction, clear-cut demarcation. And the best part, it does not cause any heat, it does not cause surrounding inflammation. That was the advantage of femtosecond. And if we compare the flap which was created by microkeratome and one that has been created by femto, then we realize that it has got better adhesion, smooth interface, obviously more precise, can be fully customizable. And as this is cutting in one plane, this is going to be planar. LASIK we cut in this manner, so they cannot be planar, obviously. There are different set of complications, different from what we get in microkeratome, but obviously they have their own complication, and visual acuity is supposed to be better here. So now we have this femtosecond LASIK, but again we are finding it problematic because now we need to create the flap with femto. Then we need to shift the patient to excimer laser. These two laser platforms are needed, so obviously you are paying like bucks and bucks of it. And then the patient, the entire time duration is extended now. So now there is another concept which came into picture. Why not let's go totally dependent on femto only. I will quickly take 1 more minute just. So that gave us the Relax, or what we call Kilex now. So they created the flap with femto. They removed the lenticule through this flap just by using the femtosecond laser, and the more refined version of it we have in the form of SMILE. That is, here we are not going to create a flap. What we will do, we will just make a small incision which is like 1/5 of the total thickness of this flap, and through this we are going to take the lenticule out. Here the advantage is we do not require to elevate the flap. We do not need to transfer the patient from one platform to another. And as this lenticule is created in the mid-stroma, so anterior portion of cornea is maintained here. Anterior portion of cornea where the collagen is so densely packed, that gives the maximum biomechanical stability and that preserves the nerve. So the dry eye chances are less and the cornea reserves more biomechanically stable. And another refined version was by Johnson & Johnson, no financial interest here, is in the form of silk that we are talking these days. Here the difference is, it's like the lenticule which we cut normally is plano-convex. This is biconvex. It is supposed to be more precise. These are the different Kilex platform that is available in market: Silk, Smile, Clear, Smart Sight. These are the different ones. So this is the fascinating story of evolution of refractive error from my side. Thank you all of you.
Thank you, Dr. Mamta. You have very nicely explained the transition from the mother of refractive surgery, PRK, to the